Thank you, everyone. Welcome to Using Fear-Free Principles to Improve Anesthetic Safety in Complicated Patients with Dr. Tamara Grubb. I'm Christy Keith, Senior Communications Strategist for Fear-Free. Before I introduce our speaker, I'd like to take care of a few housekeeping items. First, we'd like to thank our friends and Fear-Free sponsors at Zoetis Petcare for making this webinar possible. We'd also like to thank all of you for making time for this webinar this evening. We know how precious your time is. Next, yes, number one question of the century, CE is available, RACE CE is available for this webinar, and we will be sending it to you by email, the email you used to register tomorrow, Friday. If you haven't heard from us by the end of the day on Friday, please email the office at WAGS, W-A-G-S, WAGS at fearfreepets.com so they can assist you. They won't be getting back to you most likely until after the weekend, but you will get a little auto response so you can know that they heard from you. And our second most asked question, is this webinar being recorded? Yes, it absolutely is. And we will be posting it at fearfreepets.com/webinars as soon as Zoetis has had a chance to review it, and we will put it up right away after that. Also, Dr. Grubb will take some questions and she'll have time for a few at the end. Please ask them though, as soon as they occur to you rather than hoarding them, because we all know hoarding is bad. And you ask them in the Q&A window, not in the chat window, although I will keep an eye on the chat window as well. So all of that housekeeping behind us, it's now my great pleasure to introduce our presenter. Dr. Tamara Grubb is a diplomate of the American College of Veterinary Anesthesia and Analgesia with a strong focus in pain management. She owns an anesthesia, analgesia, okay, you're really just testing me now, aren't you, Dr. Grubb? Continuing education consulting practice that serves both small and large animals. She is a national and international educator and lecturer, a certified acupuncturist, an adjunct professor of, here we go again, anesthesia and analgesia at Washington State, a fear-free certified practitioner, and on the International Veterinary Academy of Pain Management's Board of Directors. She is co-author of 2 books, including Veterinary Anesthesia and Pain Management for Nurses and Technicians. Dr. Grubb's favorite achievement is winning the Distinguished Teaching Award at 2 universities, so we are very lucky to have her speaking with us tonight. Thank you so much for being with us, Dr. Grubb. Please take it away.
Great. Thank you, Christy. I really appreciate the introduction, and thanks so much for being the moderator tonight and organizing all those questions. I hope you guys have a lot of questions. I know anesthesia can be scary, so we're here to help get you over that fear. And I want to echo my thanks to both Fear-Free and Zoetis Petcare for co-sponsoring our discussion tonight. Both of these companies are dedicated to decreasing or hopefully eliminating fear, anxiety, and stress and pain in our patients. So a big thanks to them. And I also want to echo Christy's thank you to all of you guys. I get so excited when people want to come and listen to something that's interesting to me. So thanks for joining me for something I really love. I mean, look at what we get to talk about tonight. Fear-free, anesthetic safety, and complicated patients, 3 of my very, very favorite topics. So when we're talking about complicated patients, we're talking about patients like these 2 that you see on the screen. So the top patient is Harley, who is a controlled diabetic with really bad periodontal disease. So he will be anesthetized in our session for prophylactic cleaning and a lot of extractions. And the bottom patient is Fiona, a kid with chronic kidney disease, who will be anesthetized in our session for placement of a feeding tube. But as you can see by the picture, guess who forgot to take a picture of the patient before the feeding tube was placed? That would be me. So you can see she survived anesthesia, and we will talk about our protocol for her. So these are the kind of patients that we are talking about in this presentation. let's just look at their risk for anesthetic adverse effects based on their disease. And do you remember this chart in veterinary school or veterinary nursing school? We tortured you with this American Society of Anesthesiologists chart or ASA chart. Remember, this kind of delineates the risk for anesthetic adverse effects based on health status. So just quick review, ASA status patients 1 or 2 are healthy or just have mild disease. It's minimally impactful to anesthesia. ASA patients that are an ASA 3 have moderate disease that does have an impact on our anesthetic choices. And both of the patients that we're talking about today, I would classify as ASA 3. 4s are very, very sick, and 5s are going to die if we don't anesthetize them, but might die if we do. Now, what does that mean then as far as how high is that anesthetic risk based on these numbers? Let's look at this study. This is risk for anesthesia-related death, and no, death, whether they lived or didn't live, is not a good endpoint for anesthesia. But okay, it is the ultimate adverse event, and if we know why they die, we could actually keep it. We could keep them from dying and maybe make it just a complication and not a terrible adverse event. And it's easy to measure if they died or didn't. So I understand the data, and I want to look at these numbers from the study. So you can see that risk of death, the ultimate adverse event, you can see here in the red in ASA dogs and cats that are ASA 1 or 2, a fairly low inherent risk. And remember, anytime we give drugs that suppress the central nervous system or cause cardiovascular or respiratory effects, there is some risk. So there's that small risk. But as those patients get sicker, look how much that risk goes up. It goes up by more than a decimal point. And in fact, we know that as that ASA risk increases from like a 1 or 2 to a 3, and from a 3 to a 4 to a 5, that increases the risk of death 3 to 6 times. That's a lot. So what can we do about that? We need to stabilize our patients, our complicated patients like we're talking about tonight, stabilize them before we anesthetize them, if at all possible, to really make anesthesia safer. And guess what? Decreasing stress and pain are part of stabilization. Let's look at that a little bit deeper. Let's start with stress. So here we see, of course, back to physiology class, a diagram of the stress response. So that patient is stressed and that sympathetic nervous system is activated. And that stress response can exacerbate the negative effects of the diseases that our patients have. So for instance, our patients for today, that stress response can cause insulin resistant, so that's not for our diabetic, cause decreased blood flow, that's not good for our kidney disease cats. So stress can exacerbate the negative health effects. Also, stress, we've all tried to sedate or anesthetize a really stressed patient, and what's the dose? Low, medium, high? High, right? It takes a higher dose to sedate a stressed patient. And so the higher the dose, I'm going to say this more than once, more than twice, more than 3 times tonight, but the higher the dose, the more likely for adverse effects. So we want to keep that dose low. And that makes it pretty obvious then, I think, the role of fear-free and safe anesthesia. There's Fear-Free's motto to relieve. I have to move my picture here so I can see my, there you go. Okay, there I went. So our mission is to prevent and alleviate fear, anxiety, and stress, the Fear-Free mission. So their mission is not only good for the health of our pets and patients in general, but also really good for safe anesthesia. We often think of utilizing fear-free principles and techniques in patients like this who are obviously exhibiting a very high level of fear, anxiety, and stress. But I think we often forget to utilize our fear-free techniques in the patients like we're looking at today, these compromised patients, because they don't exhibit that fear, anxiety, and stress so robustly. So we may not be seeing it, but we just looked at the negative impact of the stress response. So we want to utilize all of our fear-free training to really examine these animals, to assess these animals, to watch these animals for escalation of fear, anxiety, and stress. And we'll talk a lot about that here in a bit. What causes fear, anxiety, and stress? This is just a review, but inherently the patient itself, like the patients we're talking about in this session, both of them have high FAS, which I forgot to tell you that when I introduced them, but we'll see them again at the end. Also, of course, the car ride, the cat carrier, the fasting that goes on before anesthesia. And these things are in the control of the owner to some extent. So one of my biggest tips is really communicating with that owner and getting them to be on our anesthesia team. I say safe anesthesia starts at home with what that owner is doing. So we can teach that owner that the kitty should be acclimated to that carrier and not just stuffed in the carrier the morning of anesthesia and run out to the car with the carrier going like this because the owner doesn't know to carry it like this, right, really smoothly. So teaching those owners fear-free techniques from home to decrease that stress level. And then, of course, in the hospital, there's a lot of things that cause fear, anxiety, and stress in the hospital, and we'll mention a few of those momentarily. Also, of course, pain causes fear, anxiety, and stress. And I think anyone who's been in pain, which I hope is none of you, but if you have been in pain, I'm sure you're not surprised that pain causes fear, anxiety, and stress. I know when I am painful, I am very anxious. But what you might not know, is that fear, anxiety, and stress also exacerbates the intensity of pain. So it's that vicious cycle. If the patient is painful, then that increases fear, anxiety, and stress. As the fear, anxiety, and stress level goes up, that increases the intensity of the pain. So let me just share with you some information from human medicine. We know that there is a clinical relationship between anxiety and pain. We know that the more anxious the patient is, the higher the pain intensity is, as I just said. And we also know that using anxiety decreasing techniques or drugs decreases that intensity of pain. Now, I chose a human study because we can self-report. Excuse me. We can self-report, so we can say how much pain we're in and how anxious we are. Animals can't self-report, but the pain pathway and the fear, anxiety, stress pathway are preserved across mammals, meaning they're basically the same across mammals. So if this is happening in humans, and it is, we can scientifically say the same thing happens in animals. So we really have to address both fear, anxiety, and stress and pain to have the safest anesthesia. I love this slide. It's a crazy, crazy roadmap of the consequences, just some of the consequences. It isn't even all of them, but some of the consequences of un or undertreated pain. And if you've been to any analgesia lecture I've given before, you've seen this slide. I just love this slide because it just makes us go, wow, pain does a lot of really bad things. And maybe we're more familiar with some of the things that we see on the right-hand side of the screen. So for instance, we know pain causes pain. Untreated pain can lead to central sensitization, or we might call it wind-up, upregulation. Also peripheral sensitization, which we often call hyperalgesia or allodynia. And that amplifies that pain, and that can lead to even more anxiety and fear as that pain gets worse and worse. And we know that can cause behavioral effects in our patients like aggression or hiding. So we see all of those behavioral impacts, and then also quality of life impacts like anorexia and insomnia. And then if we look at the left-hand side of this chart, boom, these are all the negative health effects. So we see the neuroendocrine changes and sympathoadrenal activation. So tachycardia and hypertension, increased cortisol release, immunosuppression, respiratory compromise, hypoxia, right? All of the things that pain can cause. So you see that we really need to treat pain for behavioral, welfare, and health. So this is a very common question. So we've got all that background now. A common question is, I have a sick patient to anesthetize. This patient is all very anxious. What can I do to make anesthesia safe? And a second part of that question is often, I don't want to give it any sedatives. So we're going to answer both parts of the question. I love this little roadmap. This is this little checklist. I use this checklist for all of my patients. It's just like a 30,000 foot level checklist. We have a more detailed one, but it just makes me think about what does that patient need for safe anesthesia in each of the 4 phases of anesthesia: pre-anesthesia, induction, maintenance, recovery. So we are going to go through anesthesia in this order, and we are going to start with pre-anesthesia, which starts with that stabilization that I talked about, that patient preparation for anesthesia. And again, just as a reminder, we often think about that in these patients and not always in these patients, right? Because they're not, as I mentioned earlier, not exhibiting such a robust fear, anxiety, and stress episode. But it's so important that we find that because of the stress response that we mentioned, and also back to the dose. I told you I'd say it more than once. The calmer the patient is, the lower the dose of sedatives, induction, and maintenance drugs. And those drugs usually have a higher incidence of adverse effects. We want to keep those dosages low. And even though the sedative dosages for the patients on the left would be much lower than the patients on the right, they might still be too high for their complications, for their diseases. So it's even more critical. These patients on the left have lower physiologic reserve. So they're more likely to have adverse effects secondary to our drugs. We want to keep those dosages low, but notice I didn't say don't give drugs. It's all about the dose. So staying at home, of course, here are some examples of pre-visit pharmaceuticals that we utilize very often in anesthesia. And there are a lot more pre-visit pharmaceuticals. That is an entire hour to spend together some other time. But I think trazodone and gabapentin are our most commonly used drugs. And I think we know the dosages and the mechanisms of action. You might notice that my high end of the dose is a little bit higher than what behaviorists recommend, and totally agree with both dose ranges. It's just a different end point. The behaviorists want long-term behavior change without sedation at home. We don't want a lot of sedate pets at home. I want to get that patient into the hospital safely, and a little bit of sedation is okay. And that's why I had those higher dosages. But really, in most of the complicated patients, we don't need that high of a dose. That lower dose, that lower end of the dose will be ample for getting that decreased fear, anxiety, and stress. The biggest tip for utilizing these drugs is give them 2 hours before stress, 2 hours before getting out that cat carrier, 2 hours before getting the car keys for to drive the dog to the clinic. They do take some time to work, so give them that time. We might need to give them the night before with really stressed patients. And then in some patients, we even need to give them for several days before the veterinary visit. But that's not the norm in these complicated patients. Usually the morning of and maybe the night before is ample. Some other drugs that the patient might need to receive at home would be the analgesic drugs. So for instance, gabapentin might be one of the pre-visit pharmaceuticals for anxiety, as we just mentioned, also maybe being used as an analgesic. Just remember that if at all possible, treat that pre-existing pain. It might be the first time you've seen the patient, so you didn't know they were painful, and maybe you didn't know they needed pre-visit pharmaceuticals, but next time we'll know, right? So we'll make sure they have these drugs. Whenever we talk about specific drugs, we need to quickly talk about the safety information, because as it says, it's important safety information. This information is what allows us to use these drugs safely. And so for instance, with the NSAIDs as a class, we know that they might cause GI or kidney or liver effects, and we need to be sure we tell those owners what to watch for and when to call. And for all of the drugs we'll talk about, if you want more information, there's a URL on the screen for every drug, every specific drug that we talk about in this session. Don't forget meropenem too. So to prevent motion sickness, it's FDA approved in dogs. And we know that emesis can also cause fear, anxiety, and stress, right? Make that patient a little bit little bit anxious. And of course, in these patients that are already complicated, it can also exacerbate, again, some of the adverse effects of the disease. So if they're vomiting, more likely to be dehydrated and have electrolyte imbalances, maybe hypoglycemia like our diabetic. So it's another thing that the owners can do for us at home to help promote safe anesthesia. And don't forget the Cerenia tablets for motion sickness are approved in dogs for acute vomiting, approved in dogs 2 months and older, and dogs for motion sickness approved 4 months and older. Okay, so now we have done our pre-anesthesia preparation. Let's get some sedatives going in these patients. And if they're really sick, don't forget, we also want to start monitoring and supporting these patients at this time before anesthesia. We also want to utilize all of our fear-free principles and techniques, handle these patients carefully. And if they are high fear, anxiety, and stress coming into the patient, or if it's into the patient, into the practice, or if they are starting to escalate, don't wait to sedate until this situation is out of hand. Right? These patients are here for anesthesia anyway. They're here for sedation anyway. Don't let them escalate to a point where this is dangerous. Just really quickly reminder of some of our fear-free patient handling techniques. And of course, you've learned a lot about fear-free handling in fear-free certification. So this is just one slide, just a few reminders. You know so much about this, but just remembering stress-free location, no barking dogs, distraction techniques, even licking an icicle pop as just a little bit of liquid, that's perfectly fine before anesthesia. And then, as I've already mentioned, start really watching those patients for their fear, anxiety, stress levels. And if it's low, we can continue doing what we need to do with the patient. If we're trying to get a full physical exam before anesthesia, if it starts to escalate, let's sedate. Here are just a reminder of some of the things that are in the hospital that cause pain and discomfort that I think sometimes we forget about. Even things like utilizing the clippers, right? That sound, that buzz, that can be really stressful to patients, the vibration on the skin, unfortunately, sometimes some clipper burn. So a lot of these things that we do that we don't think about can cause fear, anxiety, and stress, and either cause pain or exacerbate pre-existing pain. So it's all part of fear-free handling to try to minimize the time and the invasiveness that we spend on these procedures. Now I love this chart. I know it's really small type, but you don't need to read it because this is in your fear-free materials. And this chart written by Ken and Debbie Martin is awesome. So it's the stoplight where green is go. If they are low fear, anxiety, and stress, we can continue again with the full physical exam or whatever we're trying to get done with the patient. If they're yellow, we're starting to proceed with caution. And if they're red, we need to stop what we're doing. Now, again, get this from your fear-free materials and you can read all the fine print. For this session, let's just enlarge some of the pertinent information pertinent to this lecture. It's all pertinent, but pertinent to what we're talking about right now. So green, and there's some of the what we would look for green level, low FAS. If they're green, again, we can continue. If they are yellow, or especially if they're red, and you can see again some of the attributes of both the yellow and the red scenarios, sedate. Don't keep wrestling this patient. Right now, it's getting more and more dangerous because remember, we said this at the beginning of the presentation, the more anxious, the more fearful that patient is, the higher the dose. So if we can start with that sedative, we'll come back to which sedatives in a moment. If we can start with that sedative before it escalates, the dose is lower. So we call it don't hesitate, sedate, or don't be, there's another one. That's don't hesitate, sedate. It's going to have to do for now. And in your fear-free materials are these charts, and these are some sedation examples and suggestions. This one's in cats. We'll look at the dog ones next. Again, very small, but it is in your fear-free material. And for these protocols, the low end of the dose is what we usually use for the complicated patients. And then we have the same thing here in dogs. So again, you can see that green, yellow, orange, red, and some of the sedation examples in your fear-free materials. So for pre-anesthesia, we all have the same drugs, right? You know, to me, that's one of the things that makes anesthesia sort of easy, is because there's just not that many choices of drugs. We have the drugs on this list. Would I utilize opioids as a pre-medicant for these patients, these complicated patients? You bet. Very safe class of drugs, minimal physiologic effects, some vomiting, right? So we want to prevent vomiting. But reversible, I never reverse opioids, but we could, and we're starting our preemptive analgesia. The benzodiazepines, yes, very, very safe class of drugs. And you'll see in one of the patients we're talking about in the session that I did use a benzo. Just remember that if the patient has moderate to high fear, anxiety, and stress, we might want to use the benzodiazepine as part of the induction. We want it on board, but we might use it as induction instead of a pre-med, because it can cause paradoxical excitement in some patients. Alfaxalone, we tend to think of it as an induction drug, but remember it can also be in low doses, a pre-medicant. So also an option in these patients. Acepromazine, not my favorite in complicated patients, mainly because it's not reversible. It has to be cleared by the liver. So if there's any impaired clearance, those patients can be sedate for longer than we had hoped for. And the alpha-2 agonists like Dextermator, absolutely. It depends on the disease, right? But Dextermator can be used for a lot of complicated patients. Here is our important safety information for Dextermator. And of course, we wouldn't use Dextermator in dogs or cats with cardiovascular disease. That's the big one. And some types of respiratory disease, or maybe liver or kidney. And the biggest thing about Dextermator is it greatly decreases the dose of both induction and inhalant drugs that we will need for anesthesia. So that's important to know for safety. So we reduce those induction and maintenance drug dosages. And it's also important for this discussion because we want to decrease the dose of those drugs. So it makes it an awesome addition to protocols in the appropriate patients. Also, if the patient didn't get meropitant at home, don't forget meropitant in the hospital. We've already said we'd rather prevent vomiting because it can exacerbate fear, anxiety, and stress. And it can also exacerbate some of the health problems that these patients have. So we've already mentioned dehydration, electrolyte imbalance. And then also that patient that you see on the screen there, the brachycephalic patient, any patient with upper airway dysfunction, right? We do not want them to vomit because they might aspirate and then get aspiration pneumonia. So quite important in those patients. We know from data that is summarized in that top manuscript that you see there. Those are both open access manuscripts, links to open access manuscripts that you see on your screen. And we know from data in that top manuscript that dogs that receive meropitant as a pre-med actually had better recoveries. They had less uncoordinated movement. So the recoveries were much smoother. They also returned to normal eating more quickly than dogs that didn't have meropitant. And that can be very important just for overall health, but also especially in patients like the diabetic dog that we're talking about in our discussion together. It's also, I have to say, very good for client satisfaction. They're much happier when their animals eat earlier. And that's also from some data by the author of that first paper, Dr. Bonnie Hay-Krause. So our important safety information. Cerenia injectable is approved for acute vomiting dogs 2 to 4 months of age, sub-Q, and then IV in dogs 4 months of age. And of course, more information at the URL on the screen. Okay, we're back to our checklist for anesthesia, and we are ready to induce this patient. We chose our pre-meds, we've given our Cerenia, we're ready now for induction. And the goal is to achieve unconsciousness smoothly, rapidly, giving those drugs to effect. So what drugs might those be? Well, again, I have the same drugs that you guys have, and you can see we don't have a lot of choices, but we have enough choices. Which ones What do I pick for the complicated patients? Propofol, of course, is a good choice. Very easy to titrate to effect, so we can give each patient that patient's dose, right? Really watch how much that patient needs. Remember, there is some dose-dependent cardiovascular and respiratory depression, so we want to be ready to oxygenate that patient and respond with blood pressure support if we need to. Alfexilone is very, very similar to propofol, so we get that dose-dependent cardiovascular and respiratory depression. Very easy to titrate to effect. Ketamine actually also has minimal to no cardiovascular and respiratory depression. The biggest thing with ketamine is it does require hepatic and renal clearance. And so if the patient might not clear or metabolize the drug, then it wouldn't be my first choice for some patients with complications. Same with taletamine zolazepam. Remember, it's very similar to ketamine and a benzodiazepine. Etominate is that drug that we use that causes no cardiovascular changes whatsoever. And quite frankly, it's fine anytime that you want to use it in these patients. Really not necessary in the patients we're talking about. And probably most of us don't have it on our shelf. We can't have all the drugs. I would love to have all the drugs, but it gets a little expensive, doesn't it? So it's an option if you have it. The inhalant's got the big red X. You're not going to use the inhalants to induce these patients. Now, I know that some of you out there are thinking, but I was taught in veterinary school that the inhalants, if it's a sick patient, the inhalants were the safest drug class we had to anesthetize those patients. And y'all, I'm going to confess, I remember those days. It's a secret. I remember those days too. But when I was taught that in vet school, we didn't have a lot of other drug choices, right? The inhalants that was the drug choice we had. So yeah, I think at one time in anesthesia that was true, but it's no longer true. I'm going to come back to why it's not true. Here we have some good safety information. So first, for propofol or propoflow, don't forget that the propofol that we buy is not for human use. And also, if you're still using regular propofol instead of the propoflow 28, those bottles should be discarded within 6 hours of opening because there is no preservative. More information at the URL there. Ketamine, don't use, we've already mentioned this. I wouldn't choose ketamine for cats that had renal or hepatic disease. Talzol. So speaking dogs now, but similar to the ketamine, not using it in dogs with some diseases like, for instance, pancreatic or severe cardiac or pulmonary. All right, let's go back to the inhalants now. I said they were dangerous. I don't know if I said it. No, I'm saying it. They're dangerous. I said it was not the choice that we would use. They got the big red X. That cat in that chamber, and I'm sorry the picture's blurry, but it must be 100 years old. I haven't boxed a cat down in so long, I don't have a picture of it. But the stress level of that cat in that chamber is so high. And what did we say about the dose in stressed patients? So high. And it really is very, very dangerous to the patient because of that high dose. And it's a very slow onset. So they have a lot of time in there to go through this fear, anxiety, and stress response and get more and more isoflurane or sevoflurane. Now, I know some people, nobody that's listening to this webinar would say it, but I still hear it from some people. I box down cats, not me, I hear it. I box down cats and they don't go through an excitement phase, they just freeze. Y'all, what level of fear, anxiety, and stress is a frozen cat at? Woohoo, right? Like so high, I can't even measure it. Cats don't freeze. Like that is an abnormal response. That is a very highly stressed cat. And plus it's scientifically not possible for them to not go through that excitatory phase. That's one of the 4 planes of anesthesia. Remember that? The stages and planes of, yeah, okay, that was torture too. But just remember there is an excitatory phase, and that's why the induction drugs, we give them fairly rapidly. We're titrating them to effect, but we give a little bolus and wait and see what happens so that they pass through that excitatory effect without manifesting it at all. But the chamber's too slow. and the mask is too slow. So it's dangerous to the patient. Here's an even more important part, very dangerous to the staff. Chronic exposure to inhalant anesthetics can cause negative health impacts in humans. So we do not want our staff breathing in those inhalant drugs every day. Now, there is a really cool webinar on that through Fear Free. And I'm saying really cool because I'm on it. Okay, no, I'm not saying it because I am on it, but that's not why it's cool. It is actually me and a behaviorist discussing from our points of view why boxing down is so awful. And so the behaviorist had I learned so much doing that webinar. So look at your fear-free course choices and you'll find a really good webinar on this topic. All right, back to our checklist. We've induced the patient and now it's time to maintain the patient. Again, dose to effect, keep those inhalant doses as low as possible and really want to focus on analgesia and focus on monitoring and support. And notice, I just keep saying monitoring and support and haven't said a lot about it in this session, but it's because I can't talk about everything in 1 hour. I want to. But can you imagine how fast I would have to talk? Faster than that. So just know that it's very, very, very important. We're just not focusing on it in this time together. Okay, so maintenance drugs are, inhalant drugs are what we're most likely to utilize for maintenance. And one of the main reasons is that second bullet there, minimal metabolism when compared to injectable drugs. As long as that patient is breathing, it will wake up, right? So we may have to breathe for it if we accidentally got them too deep, but as long as they're breathing, they're exhaling those inhalants, they don't have to metabolize inhalants, they will regain consciousness. So yeah, that is a safety factor of inhalants. The problem is, of all of the drugs that we use in anesthesia, these really are the most dangerous drugs because they have a very marked dose-dependent impact on both the cardiovascular and respiratory system. So when I say impact, I mean depression, pronounced cardiovascular and respiratory depression, and CNS, obviously, because they cause sleep. Our goal is always to keep this inhalant dose as low as possible, even in healthy patients, but certainly in these complicated patients. So everything we've done so far, starting at home, using our fear-free handling, using our pre-visit pharmaceuticals, using some kind of pre-med, all of these are working towards keeping the induction and inhalant dose low. Now we can keep progressing to keeping that inhalant dose low by utilizing really good pain management. That is so important in every patient, but again, especially these complicated patients. So lots of options, right? We have our opioids, local anesthetics, adjunctive drugs that provide analgesia. So we do have some choices for our patients. We want to make those choices based on our knowledge of the pain pathway so that we're choosing drugs or techniques. Maybe it's something not necessarily a drug, maybe it's icing an incision, but choosing drugs or techniques from different parts of that pain pathway so that we utilize different mechanisms of action, and that amplifies the pain level that we're providing for that patient, often at a lower dose of drugs, so safer and yet better pain relief. So don't forget, use your knowledge of the pain pathway. I wanted to give a couple of shout outs, and one of them is for local and regional analgesia or anesthesia, whichever one you want to call it. I cannot say enough about the attributes of blocking nerves or the positive outcome of blocking nerves. So first, of course, we have profound pain relief. Just think about that word anesthesia. That implies total loss of sensation, right? So we're saying local anesthesia. Total loss of sensation. The other drugs are analgesics, like opioids. They decrease pain, but not total blockade of pain. Of course, that's only from the nerves that we actually get blocked, right? So we don't block all the nerves in a patient, but just think how powerful that is. That decreases the needs for opioids if we're trying to decrease our opioid use in our practices. I don't advocate opioid free if it's really, really painful, but certainly opioids can cause vomiting and dysphoria and recovery and sedation. And not all of those are what we want. Sedation, maybe, the rest of them probably not. So we can decrease our opioid dose, decrease our general anesthetic dose. So we've said that that is obviously a safety factor. Also, because of that really powerful blockade, right, the anesthesia, that suppresses that surgical stress response. Remember way back at the beginning of the presentation, and we said one of the things we really needed to do was decrease that stress in the patient, because that stress can add to the adverse effects of the disease or complicate the adverse effects the patient already has from its underlying disease. It's that powerful. Also, with that really potent analgesia, that provides better hemodynamic stability. So if we have a patient that we're doing something painful on, and we do a block and just a little bit of sevoflurane, or no block and a lot of sevoflurane, which patient has a lower blood pressure? Which patient has hemodynamic instability? Yeah, the one with a lot of sevo, right? Or a lot of iso, whichever inhalant. Also can prevent long-term behavioral responses to pain. And this again goes back to how powerful the drug class is, because the patients wake up with less pain. And also what we know from human medicine is if we do local blocks at the time we cause acute pain, that patient is less likely to develop chronic pain from the acute pain source. Right? So just because we're using local blocks doesn't mean they won't develop osteoarthritis, but using the local blocks in an incision means they're less likely to develop chronic pain at that incisional site. Now, we know this for sure from human medicine because we can self-report. And I can scientifically say, again, because that mammalian pain pathway is well preserved across species, meaning it's almost the same, I know scientifically this is happening in our patients too. And then finally, so that can prevent chronic pain development. I forgot I had that bullet, so there it is. And finally, we do know from human medicine too, that decrease in the stress response, that decreased need for inhalants may actually improve survival in cancer patients when we're using these local blocks to get those two effects. Don't have the data yet in veterinary medicine, but we could expect it to be similar. I want one more shout out for constant rate infusions. So opioids, lidocaine, ketamine, the alpha-2 agonists and combinations. CRIs, constant rate infusions, are really easy to make. There is a very good free open access CRI calculator on the website of the International Veterinary Academy of Pain Management, ivapm.org, under the professionals tab or the membership tab. I can't remember, but open one of those tabs and you'll see this really good CRI calculator. So one of the many attributes of the CRIs, one is it's analgesia provided at a really low dose over time. So these are very safe ways to provide analgesia versus giving boluses and then the patient gets painful. Bolus, patient gets painful. Started as a CRI because we're kind of suppressing, we're almost preventing, we're preempting those peaks of pain, right? And it's a lot easier to prevent pain than to treat pain. So if we keep it suppressed, that's a better way, a more effective way to provide analgesia. Now, two drugs I want to give a shout out for constant rate infusions. The first one is lidocaine. It has so many benefits. Many of us learned using lidocaine as an antiarrhythmic, and it still does that. It's also an analgesic, which is why it's in this presentation. And I use it a lot for gastrointestinal pain because it also can improve GI motility, and it has some mild anti-endotoxin properties. Now, remember, it is controversial in cats, whether it's safe or not in isoflurane anesthetized cats is unclear. Ketamine is the other drug I want to give a big shout out for. Ketamine has to be one of the coolest drugs. Remember, ketamine at a high dose works in the brain as an anesthetic. Ketamine at a medium dose works in the brain as a tranquilizer. So we often give just a little bit of ketamine with our sedative drugs in a patient who has really high fear, anxiety, and stress, and we need a little bit more effect. Ketamine works at really low dosages. We call them sub-anesthetic dosages in the spinal cord to provide pain relief. How does it do that? Well, it works here, again, the spinal cord, to prevent or treat central sensitization. And remember, central sensitization, you might call it wind up or upregulation. It's that amplification of the pain pathway where the patient is so painful, excruciating level of pain. And we often see that when the patient's really painful to start with, so maybe severe trauma, the pain is not controlled, so it just continues to escalate because of the central sensitization. We also see it in acute on chronic pain. So we're causing acute pain in a patient that already has chronic pain. So I'll come back to that for a very common procedure that we might do. So ketamine is fabulous, and you can see it's such a low dose there. Okay, back to the patient off of the drugs. Just one quick shout out for preventing hypothermia. And I wish I had some great tips for everybody, but I don't. I struggle just like everybody else does. But again, it's just like pain. It's easier to prevent than to treat hypothermia. So start warming right at induction. As soon as we induce that patient, that temperature starts to fall because the drugs cause vasodilation. So there's loss of heat. The thermoregulatory center is anesthetized, so it doesn't know to respond with shivering and vasoconstriction. We scrub the patients with fluid that's sometimes cold. We should start warming immediately, try to prevent that drop, because this can definitely add to fear, anxiety, and stress and complicate some of the comorbidities. And if you've ever been really, really cold and shivering, it's very uncomfortable, isn't it? So we don't want our patients to feel that way. Okay, finally, we get to recover this patient. And don't forget that the patients may need more attention in recovery. Unfortunately, most unexpected deaths occur in recovery. And we change that statistic by providing a little more attention to the patients in recovery that need a little more attention. If they're waking up normally, their pain is controlled, they've had no problems, okay, those probably don't need extra time. But if they are ASA 3 or greater, or if anything happened during anesthesia that just wasn't quite right, they never did breathe, no matter how low the gas was, that was an example. Those patients, something else is going on and they need a little bit of care in recovery. So continued support and monitoring is what I'm talking about, and patient specific. Maybe some patients need an ECG in recovery, or oxygenation assessed, or maybe even blood pressure measured intermittently. And then whatever that patient needs for support, IV fluids throughout the recovery. Some patients maybe need some extra oxygen, definitely some warming for most of our patients, but really critical that we pay attention to that patient in recovery, especially the patients in this lecture that have complications. And what does recovery look like in our practices? Well, I hope it looks like this dachshund right here: calm, pain controlled, waking up fast enough that we see that he's progressing, he's waking up and we're not worried that he's too asleep, but he's not having an excited recovery. Unfortunately, excited recovery, though, is one of the options that can happen, and we want to make sure that we address excitement in recovery and treat it, and that may mean providing some analgesia. So we'll be back to that in a moment. And then reversal, if it's a really long recovery, I'm going to tell you that I very rarely reverse, and we'll be back to reversal in a moment. One thing we need to do as the patients are recovering and then before we send them home is make sure we utilize some kind of pain scoring system to assess that patient's level of pain, even if you're doing like rock solid, awesome pain management. Remember, pain is a very individual sensation. And so in some patients in your practice, your rock solid pain management might not be enough for that patient. And maybe they had underlying pain to start with and caused acute on chronic pain, right? And so maybe our protocols aren't controlling that level of pain and we just didn't expect it. So we have to pain score. These are some scores that I really like to use, the Colorado State scores. They're not validated by research for pain to make sure they show pain. Clinically, I can tell you, I think that they do. I think they're very, very useful, and they're free downloads at the Colorado State University website. And my favorite one for cats is this feline grimace scale. So easy to use, so easy to train the nurses to use. And again, it's an open access free download. And there's also another very cool webinar on this. It's not me this time, but if you are a member of the International Veterinary Academy of Pain Management or a member of VIN, there is a free webinar, IVAPM VIN combined webinar on using this scale. And it was given by the author of the scale, like the woman that developed it. Is so exciting, so cool to hear everything that she went through. And then she trained us on some pictures of cats in that webinar. So you might enjoy that. Okay, so which drugs now? We pain assessed. If the recovery is a bit rocky, the question comes up a lot. Is it just delirium? Is it dysphoria, or is it pain? And I'm going to tell you that most of the time we can't tell the difference. I know sometimes some people can tell. I'm usually not very good at it. And it doesn't matter to me because we've already had this discussion. It's both. Pain can cause fear, anxiety, and stress, so a dysphoric recovery potentially. And that dysphoria, that fear, anxiety, and stress can exacerbate the pain. So don't forget to address pain. And we might need to sedate the patient with a little bit of alpha-2 agonists like Dextermator. It was in the previous slide. And remember, the alpha-2 agonists are sedative analgesics, right? That's what their job is. You look right on the label, sedative analgesics. We might need to give some more opioids as well. And just think about the opioid that you gave as a pre-med or intraoperatively and the expected duration of that opioid or the expected duration of whatever other drug you've given. And if you're getting near the end of that expected duration, you might need to give more. But we do not want excited dysphoric recoveries. Those are dangerous. Again, that level of excitement is just not safe. Now, for the next drug class that we might give, I love giving Rimadyl in dogs and Simbadol in cats. Both of these drugs, remember, last 24 hours. And so, oops, I'm going to do that. So that decreases the owner burden. So they don't have to, they might still have to give some drugs, but not as many. If we've got a 24-hour drug on board in either patient, then that might decrease what the owner has to do at home. So that decreases that caregiver burden. That's what I was looking for. And even if we didn't do something painful, don't forget about pre-existing pain. We see this all the time. We say, I just anesthetized this dog for imaging. I didn't do anything painful. Well, what about the fact that that dog has really painful lumbosacral osteoarthritis and you sedated it, stretched it, and turned it, and pulled it? What do you think that did to his painful osteoarthritis? It made it more painful. So we always need to be thinking about if that patient has pre-existing pain, and especially again, in these complicated patients. So our important safety information, we already talked about Rimadyl and the NSAID class. And remember with buprenorphine, this with Simbadol, it's very, very concentrated and we don't send it home. We give buprenorphine in the hospital. So when I said that's one less thing for the owner to do at home, I mean the Simbadol was given by me and then less for the owner to have to give when that pet gets home. Reversal, I told you guys I hardly ever do. Now, if the patient needs to go home right away, its owner's waiting in the lobby, then fine, I'll reverse it. Or if anything bad happened, right? That's the beauty of reversible drugs. If there was an adverse effect, we can reverse it. But I really don't do it most of the time. And especially these patients that had moderate to high fear, anxiety, and stress, I might give them just a tiny bit of anisetin or atipamezole just to get them extubated and make sure that they're breathing okay, but I will not give a full reversal. Why? They have high fear, anxiety, and stress. We needed to sedate them to start with. Why reverse them now? Right? We can always reverse them when the owner arrives. If they're painful, I don't reverse them because we're reversing the analgesia. And again, maybe not all of the analgesia. If we give that tiny bit of atipamezole that I just mentioned, some people call that a partial reversal. But remember that we don't know how much of the Dextermator that patient has already metabolized. It might be most of it. And then when we give a tiny bit of anisetin, that might reverse the rest of it that's left. So never count on partial reversal for maintaining analgesia, right? Because they might have metabolized most of the drug. Always address pain. And then if the patient is going on to general anesthesia, never reverse your most potent sedative, right? It makes anesthesia really hard to maintain at a stable plane and really unsafe, because now you have to have a really high ISO or sevoflurane dose, right? Don't reverse it. Leave it there. Okay, one more important safety information. For antecedent, it has some of the same contraindications or cautions that Dextermator has, some of the diseases that dogs might have. It is only FDA approved in dogs, not in cats. And sometimes, don't forget, with reversal, you can have a moment of excitement if that patient wakes up a little bit fast. Okay, so for discharge, we're almost done. Discharge, get that fear, anxiety, stress patient out of the hospital as quickly as possible. So it's back to keeping all of our drug dosages low. If we've had to use a really high dose of anything, that patient will sleep longer and have to stay in our hospital longer. What I always tell the students or clinicians that I'm talking about anesthesia with, what happens in maintenance, the maintenance phase of anesthesia, happens in recovery. So if we did really good pain management in maintenance, then the recovery is usually smoother and faster because our inhalant dose was low, yay. If we didn't do really good pain management in maintenance and our isosevoflurane dose was really high, it's still high in recovery, right? Because just because we turn that vaporizer off doesn't mean that patient can immediately exhale all of that gas. It takes some time and recovery's longer, so boom. So we want to get them home, and we want to make sure they are awake, though, not kind of groggy, because they can be very reactive. And also we want to prepare for the next visit and make sure we have a gabapentin dose, a trazodone dose, or whatever pre-visit pharmaceutical you like. And also that we have addressed underlying pain, that we have some analgesic drugs. Okay, so here's back to our common question. We want to use fear-free techniques from start to finish, from home to discharge, to help improve anesthetic safety. We want the owner to help us. Safe anesthesia starts at home, so starting with the calming drugs and techniques so that we decrease our dose of sedatives and induction drugs. Prevent or control pain always. Don't be afraid of sedatives. Remember, I told you, I hear this a lot. I don't want to sedate it. Y'all, you don't want to wrestle it. That's just adding to the fear, anxiety, and stress, and adding to the dose of all the other drugs you're going to have to give. Now, your sedative doesn't have to be something really potent like Dextermator. It can be sometimes just a benzodiazepine or just an opioid, right? A lot of, especially dogs, respond very well to just an opioid, but you still want some. And then also sedatives, decrease that dose of all the other drugs to come. Really improves anesthetic safety. So let's go back to our patients that we met at the beginning. And this is Harley. So he has stabilized, he's a diabetic that's stable, but he also has some really nasty teeth, grade 3 periodontal disease. So he's coming to us for dental prophylaxis and extractions, but he also has really high anxiety, really high. And sometimes he just can't help it. If he gets so stressed, he sometimes nips just a little bit. So we don't want to put him there, right? We don't need to make him do that. That's not fair to Harley. So let's start with our gabapentin at home. Then we would see, then what we did, pre-med with just a little bit of dexmedetomidine and some hydromorphone, because remember, he's really high stress and sometimes he bites. So I want this potent sedative. So I've got dexmedetomidine, some hydro, so our preemptive analgesia, and definitely the meropitant, no vomiting. This was our induction drug of propofol, just 2 milligrams per kilogram. I gave some midazolam with it to keep that propofol dose low, and also as our anxiolytic. Maintenance, he got local blocks, he got a ketamine infusion. And this is the case I promised to come back to, acute on chronic pain. They had those really painful mouths. We go in and cause acute pain by pulling those teeth. That acute on chronic often leads to central sensitization. Ketamine infusions are amazing for these patients. And remember, it's a sub-anesthetic dose. It's really low. Even in a patient with renal disease, I'm not worried about ketamine at an infusion dose. And you can see we were able to keep the isoflurane low. So the blood pressure stayed normal. You can see his markers of ventilation and oxygenation are normal. His blood glucose was normal. And recovery, he woke up really fast because he didn't have a lot of inhalant to exhale, and he didn't have a high dose of any of these other drugs. So 7-ish minutes extubated, normal body temperature. Within an hour he was eating, and that's my goal with diabetics, a small meal of soft food as soon as they're really swallowing, so we don't have to worry about choking, and his blood glucose was normal. Now, what if, and we've all done it a long time ago before we learned about fear-free techniques, what if we didn't do anything at home? This is what I would predict, and this is what's happened to me before I learned fear-free at home. Higher dose of dexmedetomidine, remember he bites, higher dose of dexmedetomidine, still the hydro and the meropitant, higher dose of propofol, higher dose of isoflurane. We still did the blocks and the ketamine, but we just never had a good baseline in this patient. So what does that do to blood pressure? Drops it. Now we need dobutamine. What does that do to breathing? Drops it. Now we have to breathe for that patient. Had a blood glucose of 220 from all that stress, right? That stress response we keep talking about. Recovery took him a little bit longer to get extubated. And so like, oops, sorry. Like, sorry about that. So like I said, I like them awake and eating, and that didn't happen with him. So he had lower blood glucose, so we had to run a dextrose infusion. And so really look at the patient on the left, more stable all the way through. So this is how we anesthetize our patients with complications, our complicated patients. One more, and then question time. And I know we're running a little bit over, but I will stay and answer your questions. So here we have Fiona, our kitty with chronic kidney disease and really high anxiety. She hid under the bed for a whole week when there was a house sitter. The house sitter never saw the cat, so she wasn't really drinking or eating, and now she needs a feeding tube. And as I told you guys, I forgot to take the picture before the feeding tube, but there she is with the feeding tube. So 50 milligrams of gabapentin at home and pre-medicated with Cimbadol, followed in an hour by Midazolam, and it was enough for her, right? She's really kind of she's a pretty high, she's pretty sick, this kitty. Got the catheter in, gave her just a tiny bit of propofol, local block at the skin incision, really low sevoflurane, normal vitals, quick recovery, body temperature 99, very calm, alert, ready to go home within 2 hours. Nothing at home. Well, Cimbadol, again, good for our analgesia. Midazolam alone was not enough. That was a bad choice. So we could not catheterize her. We kept wrestling her. She got more midazolam, maybe another drug added to it would have been better, but this is what she got. Finally got her catheterized, took a lot of propofol. You can see that it took a higher dose of inhalant. So look at her blood pressure, very low. She's actually hyperventilating. So not respiratory depression, but I think she was just so stressed. And then recovery was terrible. She woke up really, really quickly, thrashing all around. Body temperature was high, probably from all that excitement. Had to give her a little bit of dexmedetomidine to sedate her, so she was calmer. And then it took us some time to get her really to a good point to be discharged. We just never had control of that cat. We don't want that. So that's it. And Christy's here with us now to tell me any questions. I would love to answer your questions.
Hi, sorry I keep popping on and off. My internet is coming and going, so I apologize if I vanish again. I'll come.
Do you know? I didn't even notice. Thank you for the apology, but I didn't know you were gone, but I'm sure glad you're back.
Popped on really and off like 4 times there in the last few minutes. Yeah, it's kind of scary for me because I didn't know if when I left the whole webinar shut down or what happened. So,
well, I kept talking. So.
Excellent. Thank you. You have a ton of questions, so let's get through as many of them as we can. The first one is a number of people want to know how they can get a PDF of your slides. So I'm wondering if that's something you can make available to people. If so, how could they get it? And if not, that's fine. Just let me know. Let us know.
You know, I am always delighted to share my slides. What we need to do is check with Zoetis and Fear Free. Since they sponsored this session, I need to make sure that they they will make them available, but I'm delighted to share them. So we will check on that. And then Christy, how can we let them know if
I'll ask I'm not 100% sure, but definitely I'll put it on social media. So keep an eye on our Facebook, Twitter, Instagram. Well, not Instagram, Facebook or Twitter or LinkedIn. We'll post it there with the link to the recorded webinar.
That's great. And yeah, and remember it is recorded too. So you will get to see
Yes.
it again on the Fearful website.
That's right. Okay. A couple questions about, okay, we're going to test my pronunciation again. Cimbadol, is it Cimbadol?
Yes, correct.
I can do buprenorphine, but I'm not, always good at all the brand names here. Okay, so one of them was seeing it caused anxiousness and sleeplessness. Is that something you've seen? And the other question was about hyperthermia with the same drug. Have you seen either of those things in any significant numbers?
Very good question. And, I like the clarification at the end. I've seen neither in significant numbers. And I have not seen hyperthermia with Cimbadol. I've seen slightly elevated, I guess hyperthermia, but not always less than 104. So not even treatable in my book. And then I have seen some cats that get a little restless, a little agitated, and some that get a little bit more sedate than we want. And that's usually when we're using the label dose in patients that might need a lower dose. So off-label, completely off-label, in those patients where I've done really good multimodal pain management, or in those old cats or sick cats where I think they might be slow to clear that drug, I actually use a lower dose, completely off-label, and no proof that it lasts 24 hours, but my clinical impression is that it does. So if those are the issues that you're having, consider using a slightly lower dose in those patients, off-label.
Got a number of questions about treats, and I know that you discussed this, but the questions did come in after you discussed it. So I think maybe it needed a little clarification. People are still really stuck on the idea that giving any amount of food or type of food prior to anesthesia is off the table. And so are asking, what can we do when we can't give, because we can't give treats? And also someone specifically asked, is squeeze cheese okay to give to a fractious, or I would call them a fearful patient before anesthesia?
I love you guys. I love the way you're thinking. Did you see the big smile? Thank you for that question. I should have addressed that in the webinar. My apologies on that. Yeah, for one thing, we've really shortened our fasting recommendations. More like 6 hours is enough for most patients because fasting stresses out the patients as well. And then giving little bits of treats to get in those pre-visit pharmaceuticals to make the whole anesthetic episode safer. We are all for that. Like love giving a little bit of peanut butter with some gabapentin or whatever it takes. And also even in the hospital, and yes, the cheese, licking up the cheese. If dogs will lick those frozen pops, those frozen like beef broth, that doesn't really put much in the stomach. So that's a nice way to go, but you can't really wrap the treat in it, right? That's more of a distraction technique. Here's the deal. Just treat every patient as if they had some breakfast that morning. And how often has that happened to us in anesthesia that a patient gets injured or something happens that we need to anesthetize it right away and it ate breakfast. So what do? We induce with one of our fast induction, intubate, and take that cuff. So absolutely give those kibbles, those treats. The trade-off is awesome. And then just don't forget, intubate and inflate that cuff. Induce, intubate, inflate the cuff.
Great, thank you. Sorry, I was just looking at, somebody asked something in the chat, but they also asked it over here in the Q&A, so we're good. Couple questions about Cerenia. One, how long before the car ride do you give Cerenia? I almost answered that because I have a dog with car sickness, but I will let you answer it since you're here, the expert. And the other one was a little longer. So if you want to tackle this one, then I'll give you the next one separately.
Yes. Well, I would love to know what does work for your dog. How far in advance do you give it?
I actually like to give it to him 4 hours ahead of time, although I know that's not the label. And I also give him Cilio because he's anxious about his car sickness.
Right,
So,
Cilio, the dexmedetomidine gel. Yeah, another
now we're in trouble because that's off label. So sorry, I shouldn't have said anything, but that is what I have found works for him. Yeah.
Good for you. I'm glad you're exploring exploring what he needs. That is so cool, Christy. Yeah, another off-label potential pre-visit pharmaceutical. So God, it's a whole like 2-hour lecture for me. So many things we can utilize. So yeah. Honestly, I usually give it off the label, the dexmedetomidine, the Cerenia for motion sickness. But do what Christy does and find what works for your dog. There certainly is an individual variation on how far in advance they need that drug. But don't short it, right? Don't give it too close to the car ride time. Give it time to work.
Oh, yeah. You don't give at least 2 hours, you may as well not bother giving it to him. Yeah.
Yeah.
And because he gets really car sick, and he's a 120-pound dog, so I don't enjoy that at all.
No, he doesn't either.
Oh no, neither of us is happy. So the next question, Serenia question, is about the injectable. Do you give Serenia at the exact time as you give the pre-med drugs? I find it is an injection that the patients are very reactive to, increasing fast. Do you wait until they are sedated and then give it?
Yeah, such a great question, and good for you. Good observations and good ideas on how to work around the sting. I try to give it an hour before I give pre-meds, because remember, it does prevent the vomiting from the opioid. So I would rather give it ahead of time. If the patient has a catheter in, don't forget, you can give it IV. And also for the sub-Q injections, it's the only drug that I know of that's this way. But remember, keep it cold. Keep it in that refrigerator, right? Like that's opposite of like local anesthetics. You warm them up to decrease sting. With Cerenia, you want it cold. Keep it in the refrigerator. Decreases that sting. So I still try to give it ahead of time. And I don't like sting. Nobody likes sting. But that little sting from giving the drug, compared to 24 hours of not vomiting and better recoveries and faster return to eating, I don't like sting, but I'll take that trade-off for that benefit. But if really you really don't like it, yes, giving it after the patient's induced or pre-medicated, it still will be working in recovery, right? So you're still getting the faster return to eat. Well, I think there's no study, but you're still getting benefit from it. So that is an option.
Great, thank you. For lidocaine in cats, is it not recommended to use as a CRI IV only? Is it only with isoflurane? Excuse me. Is it fine to use for local block, i.e. line block laryngeal spray?
Absolutely. Superb question. So lidocaine, as you just described it, using it for local regional blocks and on the arytenoids, absolutely perfect. Of course, cats take a slightly lower dose than dogs. So like with everything, get the dose right. There is one study in cats, only one, that showed the lidocaine infusion in isoflurane anesthetized cats actually worked. It did provide some analgesia, but it also decreased cardiac function. There's only the one study, but it's from an amazing research group, so totally good data. But we don't really know anymore from there. So the CRI, that's why it's controversial. I'm going to be honest with you. I do use lidocaine infusions in conscious cats, especially those with GI pain like pancreatitis. Love it for pancreatitis, but that's just me, and you don't have to be like me. So do what makes you comfortable, but keep doing those local blocks with it.
I teach for an RVT program, and I'm looking for a sedation protocol that we could use to sedate our feline patients and not drop the blood pressure so the students can practice blood drawing. Any thoughts?
Yeah, that's a really, really good question. And it might end up being a protocol that would, if they want to practice blood drawing in cats, as much as I love Dextermator, vasoconstriction can make it difficult when you're learning. Now, all those of us that have been doing it for years go like, oh, Dextermator, no problem. But learning is different. It might be a ketamine benzodiazepine protocol. I tell you what, though, we need to talk more about that. So anybody who has a question can email me, but please especially email me that one, because I need to know more about what you need. So Tamara Grubb, I'm going to type it in the chat right now. Let me see where I can find. I'm finding the chat, and it is TAMARAGRUBB at wsu.edu. I'm using a different keyboard tonight, and I'm a disaster. Okay, there we go. So please email me that question.
Great, thank you. Do you try to avoid using propofol in dogs with pancreatitis?
No, great question though. We thought that would be a problem, but really, honestly, it's not. Just like with any other disease, pain meds on and use a low dose, but no, I don't avoid it.
Great. Here's a shelter question. I'm currently working as a CVT at my county's animal control where we are using trazodone and/or gabapentin for dogs for anxiety, kennel stress. I just want to say I love shelters who treat the anxiety of their animals. It's so wonderful.
Yeah.
There has been debate as to whether or not it is okay to give them the morning of their surgery. I think our DVM is worried about giving the meds in a pill pocket and then taking our patients to surgery about an hour later. I'm leaning towards it being okay if it helps decrease stress. Am I wrong?
You're definitely not wrong. You are 100% right. And Christy, I agree with you. Kudos to you and your shelter that you are decreasing that fear, anxiety, and stress. Those, I'm sure it's so high in a shelter situation. It's busy, it's loud. No, you are right. I would definitely give those drugs, and I would have your DVM, or you tell the DVM, and then you're probably the one giving them. Don't wait till 1 hour before the surgery. If you can, give it about 2 hours ahead of time. That gives it a little bit more time to clear the stomach. You could even give it 4 hours ahead of time and give it time to clear the stomach. But 2 is probably just that sweet spot. And then, like I said earlier, then have the DVM treat that patient like it had something in its stomach, give it the induction drug, put that in the tracheal tube in and inflate the cuff, right? So that if it did regurgitate a little bit, you could protect the airway. But quite frankly, that morning pill, even in a pill pocket, really makes a world of difference to those patients. So good for you. You are right. Give it that morning.
Great. Some people are saying that they didn't see your email appear in the chat. So I am typing it.
Oh, yes. Thank you, guys. Because guess what I did? I sent it to the panelists. So that's me and Christy. So me and Christy got my email.
Oh, and now I typoed it. Okay, everybody ignore what I just typed. Let's try that again. Tamara Grubb
Right.
at wsu.edu, Dr. Marty Becker's alma mater.
Absolutely. But there we go. There we go. Second A. Good. Or third A. Yeah. It's like Canada, right? C-A-N-A.
Yes.
So mine's T-A-M-A. So
Mississippi, exactly. It just to get
so thank you guys for telling me. It's because I couldn't work the chat list.
Okay, we have a few more questions. Are you okay to, I know we're way over time, and if people need to leave, I see we're still well over 300 people. This should probably almost certainly be included in the recording unless Zoetis prefers to remove it. So let's just jump in and maybe do a little bit of a lightning round. Is there any sedation effect with Rimadyl or Onsure?
No, there is no sedation effect with the NSAIDs, but sometimes if a patient is painful and we give them an anti-inflammatory drug, which is very powerful, you will see them calm down. It's because we've taken away the pain.
Very good. Do you use lidocaine gel at catheter site before placing the catheter?
I love lidocaine gel and catheter sites before placing the catheter. And I don't always do it, but if in these patients with high fear, anxiety, stress, I try to always do it. And when I'm teaching, so there's going to be a lot of catheter sticks, then I always do it. But yes, I do. I love that.
Can we clarify quickly whether Rimadyl lasts for 24 hours per dose?
Rimadyl does last for 24 hours per dose, which is why I love it. 1 dose, 24 hours of pain management. And that's on the label. So if you want more information, definitely look up that product label for Rimadyl.
I'm skipping a couple of these because they would be too lengthy. Using the ketamine infusion, do you place those blocks in the same spots as bupivacaine or lidocaine oral blocks?
Would you repeat that one?
Using the ketamine infusion, you place those blocks in the same spots as bupivacaine or lidocaine oral blocks.
So the ketamine infusion is sorry, I didn't say that very well, did I? The ketamine infusion is intravenous. So you've got your IV fluid bag and then a little pump or another little bag with ketamine in it. So it's going intravenous, and then your blocks are still the same wherever you put your oral blocks. So they're two separate injections.
Okay. One second. Okay, a lot of these are coming in now, and some of them are quite lengthy. I'm sorry, we are going to have to wrap. We're already 20 minutes over. But let me ask one. I want to say how many people asked about fractious cats. And I hope that you don't mind if I once again say, try changing the word fractious to the word frightened. Cats mostly who act that way that we call fractious are just terrified. And when we call them fractious, it kind of creates the feeling that they're bad. They're not bad, they're scared. And so I'm sorry for jumping in with a PSA in the middle of your Q&A here, Dr. Grubb, but I hope you don't mind.
I don't mind at all. Thank you for jumping in. I appreciate that. And that's a really good point. And I accidentally still use the word because it's so ingrained in my head, but it is true. And it happened with one of my own cats. He was a bossy cat at home, but he was, he seemed pretty agreeable. And he actually fractured a toe, took him in to work, left him with radiology. And they called me up and said, come get your cat. He is terrible. And it's just because he was so scared and he was painful. I mean, he never had shown any incidents of that. So thank you for that reminder. So, and hi, Tesla. I got a personal note. I haven't been able to see all of the chats, but I see Tesla who,
Rob Downing said hello. A couple people who had to leave right on the hour because they had other commitments, said they were sorry they had to leave before the Q&A. Do watch out for the recording. And we are, just so incredibly grateful to you all for being here. We are out of time. We are more than out of time. And I didn't get all your questions. I wish we could have. But thank you again so much for being with us. Thank you, Dr. Grubb, for a fantastic webinar. And thanks to Zoetis Petcare for making this presentation possible. For those attending tonight, we will be sending out the CE email tomorrow, Friday, and you can email us at wags@fearfreepets.com if you don't receive it. And I did put that in the chat window, and I don't believe I typoed that one. And we hope we'll see you next Thursday, May 20th, also at 8 p.m. Eastern Time. For, yes, you can perform a fear-free canine orthopedic exam with Dr. Kristen Kirby-Shaw. You can register for that at fearfreepets.com/webinars if you haven't already received an email or seen one of our many social posts about it. And of course, that is also where the recording of this webinar and all our recorded webinars will appear, usually within a few days to a week after the live event. Thank you so much, everyone, and good night.
Thank you. Thanks so much. Email me if you need me to answer a question.